In this session, we will be discussing the hemodynamic monitoring. Why? Why hemodynamics is important? Hemodynamics is the study of dynamic behavior of blood, both non-invasive and invasive techniques that can be used to determine hemodynamic status of the patient. Non-invasive hemodynamic monitoring can be determined by cuff blood pressure, or what we call it non-invasive blood pressure. Invasive monitoring involves direct measurement of blood flow pressure within the heart and artery. The purpose of invasive hemodynamic monitoring is to provide immediate accessible information of the client's cardiovascular function to allow for early detection, assessment, and treatment of acute conditions, evaluate the patient's immediate response to treatment. Invasive hemodynamic monitoring includes intra-arterial catheter, or a line, or arterial line, and central venous pressure catheter, or what sometimes call it CV line or CVC, which is central venous catheter. Hemodynamic monitoring system consists of bedside monitor, which include the amplifier, and the amplifier function is increasing the size of electrical signals to be visible on the screen so we can interpret. Transducer, change the mechanical energy of pressure of pulse into electrical energy that should be level within phlebostatic axis, and you can estimate this by intersecting lines for the fourth intercostal space mid-axillary line. And finally, we need a recorder to review the patient history and about hemodynamics, and nowadays it's all electronic, saved on the monitor itself. This figure shows the components of the transducing system or hemodynamic monitoring system. This is the transducer. As we mentioned before, it's transducing the mechanical energy comes from the heart and the pulse and the flow of the blood in the vessel to electrical energy that can be interpreted and be visible on the monitor. The mechanism of the transducer. Hemodynamic pressure are transmitted from the intravascular space or cardiac chamber through the catheter and the fluid in the non-compliant pressure tubing to the pressure transducer. A pressure transducer sends changes in the fluid column generated by the pressure in the cardiac chamber or vessels being monitored. When pressure is applied to the diaphragm of the transducer, sensors are compressed, changing electrical flow to the amplifier or monitor. Pressure transmitted from the catheter in the patient to the transducer occurs through fluid filled in non-compliant pressure tubing. The patency of the hemodynamic monitoring system is maintained by the continuous infusion of a flush solution. The flush solution is a normal saline and may be heparinized, but as per policy in hospital in PSMMC, we don't use heparin. The solution is placed in a pressure bag that inflated to 300 mm mercury to maintain a constant pressure through the transducer and flush device. Of course, zeroing is a process or a small procedure should be done for any patient connected to a transducing system, and zeroing actually is talking about considering the atmospheric pressure is equal to 0. Transducer placed below the reference point produce falsely high reading, while transducer placed above the reference point produce falsely low reading. Reference point, which is the intercostal space, mid-axillary line, in the fourth intercostal space crossed with a mid-axillary line, which is the phlebostatic axis. And this can show us the phlebostatic axis. Arterial line, which is the first part of the hemodynamic monitoring. The arterial line is a cannula usually positioned in a peripheral artery such as radial artery, which is the most common useful one. Brachial artery, it's contraindicated unless the one who's going to perform the catheterization is an expert person. Dorsalis pedis artery, femoral artery, which is not recommended because of the infection, because it's near to the groin area, which is a source of infection. Provides continuous readout of systemic arterial blood pressure, provides vascular access for arterial blood withdrawals. Before insertion of arterial line, we have to perform Allen's test, and that is specifically when we are using the radial artery. So the procedure is, we have to start by occluding both radial and ulnar artery, clench and unclench fists until hand blanch, release pressure from an ulnar artery. Color should return 5 to 7 seconds. Color means the red color of the hand, and this is actually to find out the patency of collateral circulation through ulnar artery. Most common sites are the radial and femoral arteries, but radial artery is most used and provides least limitation in patient mobility. This figure shows us how to perform the Allen's test, and as I mentioned before, this is only specific for using the radial artery as an axis. Indications for use arterial line: ease of access, patient with unstable blood pressures, continuous monitoring of arterial blood pressure, especially in a case if a patient is on inotropic drugs or if the patient is on a vasoactive drugs, for example nitroglycerin. If a patient requires frequent arterial blood sampling and laboratory, and this is very common in the ICU, especially if the patient is ventilated for ABGs. This figure shows us the ideal arterial wave on a monitor, and it shows us the top of the wave will be the systolic blood pressure, and the lower part of the lower limit of the wave will be the diastolic blood pressure, and we can see here the dicrotic notch, which is representing the closure of the aortic valve. Mean arterial pressure, or what we call it usually as an abbreviation, MAP. The equation is very simple to calculate. By the way, if you are using hemodynamic monitor, it's automatically calculated on the monitor itself, but the equation to calculate is 1 systolic plus 2 diastolic, and the total will be divided by 3. Complications associated with arterial line: hypovolemia, accidental intra-arterial injection of drugs, local damage to artery, infection, impaired circulation to extremity. Nursing consideration: compare blood pressure with auscultated pressure, make sure that the catheter is patent, no IV solutions or medication should be given through the line, access for adequate circulation, assess for adequate circulation, sensation and movement of extremity, tightly secure connections to prevent exsanguination or accidental removal, assess site for signs and symptoms of infection, bleeding, hematoma, and tube kinking. Set high and low alarm 10 to 20 millimeter mercury of patient's baseline. Now we'll be discussing the central venous pressure. What is the central line? Indwelling catheter inserted via subclavian jugular, antecubital or femoral vein and positioned in the vena cava close to the right atrium. Connected to hemodynamic monitoring system, reflect right atrial and right ventricular and diastolic pressure. Indications for central venous line: fluid resuscitation, inotropes administration, parenteral feeding, measurement of central venous pressure, poor venous access, and administration of irritant drugs such as electrolytes. Central venous pressure or CVP normal range is from 0 to 6 mm mercury, and this measurement actually for non-ventilated patient. For a ventilated patient, that will be totally different because the intrathoracic pressure will be increased because of the ventilator and the pressures caused by the ventilator itself. Reflects pressure of blood in the right atrium or vena cava, provides information about intravascular blood volume, right ventricle end diastolic pressure, and right ventricle function. CVP indirectly reflects the left ventricle end diastolic volume and function. Measure of the preload and depend on volume. Increase in central venous pressure indicates increase in blood volume due to sudden shift of fluids, excessive IV fluids, sodium water retention, or renal dysfunction. Again, increase in CVP may be caused by the right ventricle failure and mechanical ventilation, and those are the two most common causes. Drop in CVP indicates a decrease in circulating volume due to hemorrhage, hypovolemic shock, or vasodilatation. A change in or trend of the CVP is most significant than actual numerical values. Even everything is still within normal, but sudden drop in a big range of the central venous pressure, it's very important, and the physician must be reported. CVP complications: malposition of the catheter, hematoma, arterial puncture, pneumothorax, hemorrhage, sepsis, air emboli, catheter embolism, thrombus, hemothorax, cardiac tamponade, and cardiac arrhythmias. Thank you very much for your attention.